Thank you. So welcome everyone today. Really excited to present this and work with my colleague, Jim. I am a senior fellow at NACHC. I've had a long history of working with community health centers across the country and as well as philanthropy and academia, and have worked at primary care associations to have a good sense of the landscape. And it's been a pleasure to present this today. I'm going to hand it over to my colleague, Dr. James Lavery.
Thank you, Wanda. Thanks for the introduction, and thank you all for joining today. I'm Jim Lavery. I'm a professor in the School of Public Health and at Center for Ethics at Emory University, and one of the investigators on the project that we're going to talk about today. And it's a real pleasure to be here with Wanda. We have spent probably more than 100 hours together on this project, and particularly satisfying to be able to share back some of these findings with all of you, since NACHC has been just such a rich contributor to this project.
Thank you. So the first thing I want to do is thank all the health centers that were part of this process with us, located in various parts of the country. Without your help and their key contact at each health center to help engage both staff and patients to participate in these interviews, this work would not be possible. And I want to give a special shout out to my colleague and partner in crime, Sarah Price, who worked very closely with me as well, and our communications team. I wanted to kind of set a national landscape of where we are, and NACHC is partnered with HHS on the We Can Do This campaign. And one of the benefits of working with partners is to have some big national kind of picture of where we are with COVID and why I think this topic is so crucial. As you know, we still have COVID in our country. It's still kind of going around, and we have patients that are still in this kind of undecided box. And some of these people are what we call the movable middle, the opportunity there is in engaging them in getting vaccinated. And as I think where we were a year plus and where we are now children can also qualify to get vaccinated. And what I wanted to just bring attention to were these are some of the top 30 states where the baseline is in these counties, in these states where the vaccination rates are still low, but there's an opportunity to engage these people in getting vaccinated. When we looked at parent demographics and where parents fall on getting their children vaccinated, again, a good kind of landscape of the top 30 locations where vaccination rates for children remain low. And I think we have health centers that are front and center in a lot of these communities. And where is the opportunity to apply some of the information we'll learn today, along with other strategies, to have these conversations with parents? At the end of the day, they are the decision makers to help vaccinate their children. And this is information on boosters. So as we look across the life cycle and the spectrum of people who are eligible for boosters, who are in this, due for a booster, have gotten at least one vaccination, but haven't come back for boosters. And these numbers are a little better, but still, I think of this as where we will be heading. What the news is telling us and data is coming back now around long COVID, what can we do to help prevent that? And how can we continue to work towards engaging our patients in conversations and help them make an informed decision about getting vaccinated? I'm going to turn it over to my colleague to share what we learned from this work.
Excellent. Thanks so much, Wanda. And I think that those slides, those data really provide a very clear picture about how we hope some of this information could be relevant. So as Wanda said, I want to talk about counter narratives as a strategy for promoting COVID-19 vaccination with patients. And this is reporting out some lessons from the COVID project. I won't read the whole name, it's a long name, but you can see it there. We really tried to address three key questions in the COVID project. One is, what reasons do people offer for not getting vaccinated for COVID-19? And number two, are any of these reasons changeable? And number three is, if so, then how can we develop and deliver effective public health messaging and communications to the right targets. So my program at Emory is called the Human Engagement Learning Platform. So we're very much interested in stakeholder engagement and trying to understand and learn from stakeholders in a sort of human-centered design approach. Our contribution to this project was to generate an evidence base to support communications teams and healthcare practitioners like yourselves to address COVID-19 vaccine hesitancy. And what we've tried to do is to describe prominent narratives that appear to be shaping people's reasoning about COVID-19 vaccine avoidance, and to develop some criteria for identifying counter narratives that might help to challenge the influence of these narratives, and then to identify some specific counter narrative criteria and some targets that might help guide communications. Just very briefly about the sample, we did about 52 focus groups, or what we call design groups. We had 6 individual interviews, so really more than 300 individual participants in total. About 90% of the sample was African American, about 85% of the sample were women, and about 85% were between 45 and 65 years. And approximately 95% of all the participants were unvaccinated. And as you see, this was a main central partnership with NACHC, but also with GHC3 and the Morehouse School of Medicine, and also the Rural Studies Institute at Georgia College. So what did we learn? Well, the first thing we learned was, we recognized a number of prominent themes, which won't be surprising, but it's really worth kind of walking through them. The first is that we heard a lot about histories of discrimination and marginalization in the communities that we met with. Second, we heard a lot about suspicion of the political and social and economic motivations of authorities, in particular government. We heard a lot about what we've called information mayhem, and I'll tell you a bit more about that in a second. We heard a lot of what we have characterized as avoidance tropes, and these are stories or reasons for not getting vaccinated that are false or largely false, but nonetheless are seem to be highly acceptable within the communities that we talk to. And then really importantly for this presentation, we were able to identify very clear and very common narratives that seem to be shaping people's rationales for avoiding COVID-19 vaccines. And the asterisk there is, that's not where we started. Initially, we thought we were going to be generating personas like you would in the human-centered design approach. But in fact, what we found was that they were quite tricky to find for a number of reasons, but the narratives were very prominent. So on the histories of discrimination and marginalization, we heard a lot about intergenerational experiences of discrimination and disregard, where older participants were telling us that these experiences were being passed down through families, through stories, through their communities. There was a lot about the extreme history of marginalization, especially in African American communities, in the healthcare system, this idea of medical apartheid. There were also a lot of comments about the kind of landmark reference events in research in experimentation, in particular the Tuskegee syphilis studies that are so prominent in that history. And one of our participants talked about this through line of injustice and said that it's impossible to understand how people are approaching these decisions without taking into account this through line of injustice that tracks through all of society and all of their experience. These histories of discrimination, excuse me, and marginalization clearly create a lot of suspicion and resentment and grievance and defiance and antipathy towards government largely, but also just in more general ways towards authority and authority groups. And these attitudes significantly undermine the willingness of people to believe or to place trust in authorities and especially government. They also create what we think of as oppositional conditions, like they really feed the us versus them feel that's so prominent in society at the moment anyway. And this makes it even more difficult, I think, for many people to place trust in anyone. And it was, I think, sad to hear how many times we heard people say, I just don't trust anyone. And that was a very, very prominent sense in our conversations. We've characterized the ecosystem for information as information mayhem. We heard about scientific uncertainty and conflicting science. We heard about inconsistent and confusing public health communications, about lay epidemiology. So that's when your neighbor's cousin got vaccinated and then died immediately. And then people draw broader conclusions from that observation. We heard a lot about inconsistent and inaccurate media reports, and a lot about political manipulation of information, and of course, all of the misinformation and disinformation that was so prominent in all of the news. And of course, all of these different sources of information get churned and filtered through media, through social networks, and through social media. And what happens then is out the other end, there was a really palpable confusion, dissonance among people, and like I said, these kind of oppositional attitudes that people had. I mentioned this idea about avoidance tropes, and the information mayhem that I just described, it seems to produce a lot of these, specious or implausible or frankly just incorrect or false positions that people adopt, and these become acceptable justifications for vaccine avoidance and rejection. So for example, these are just some of the things that we heard, that the COVID vaccines were developed too fast, or the government is using COVID-19 vaccines to control the population, or that so many people are dying from the COVID-19 vaccines, or the vaccines make you infertile, or we're living in a communist state. So each of these is either completely false or at least importantly, partially false. But when they were said in the context of our focus groups, it was amazing to just watch all of the heads nod in approval. So these ideas clearly have a lot of social currency, even if they are false. So I want to focus now on what we're calling the avoidance narratives. So let me start just to make sure we're all on the same page, to just talk briefly about what a narrative is, because the word is very common. And I like this quote from the actress Julianne Moore, which I thought was really fitting to the experience that we've had in this project. And she says, "We impose order and narrative on everything in order to understand it. Otherwise, there's nothing but chaos." And so I think these stories, in fact, have such currency because of the complexity and the chaos and the information mayhem that's out there. But a narrative is a set of events and related elements. So it's the rationales, the motivations, the goals that people have that are linked in some kind of temporal and logical sequence. And that's a story, right? That's just essentially what a story is. So, and the stories are recounted or they're told by a narrator, usually for a specific purpose. So for example, to make sense of something that's complex, to explain or to justify something for accountability, sometimes for entertainment, or to manage their social status, depending on the context. Narratives about real events, which is what we're talking about today, are vulnerable to what is called the narrative fallacy. And that's that it's vulnerable to different kinds of embellishments or simplifications or accommodations or other kinds of distortions that are made in order to fit a story to a specific structure or specific social purpose. So in other words, to maybe tell a story in a certain way and embellish certain things to signal allegiance to a specific social group or political group. And of course, all of this can alter the reliability or the validity of the story or the narrative. And some examples of these kinds of embellishments are, people say the COVID-19 vaccine side effects are worse than COVID itself, or government and vaccine companies don't care about safety, they just want to make a lot of money. Of course, these things are real distortions of even what underlies it as kind of complex ideas. So I want to show you a quick overview of the 6 main avoidance narratives that we developed through our analysis. The first at the top there is the big push, and that's the idea that government and industry manufactured a false crisis and developed vaccines recklessly. The second narrative is it's not worth the risk. So the risks of vaccination outweigh the risks of COVID-19. The third narrative is it's about freedom, where the story is that vaccination is a personal choice and vaccine advocacy is coercive in any form. The fourth narrative is that COVID vaccines are unnecessary. So in other words, there are other ways of managing COVID-19 other than vaccines. The fifth is what's the point? That vaccines don't prevent people from catching COVID anyway, so what's the point in taking the vaccine? And then the final narrative is waiting for more information. That we heard a lot of people say there's just not enough information yet to make a decision.
Jim, before you go to the next one,
Wanda.
just leave it there for a second. To the one you had, I think it's important for our health centers to know that those those kind of themes were consistent, whether we were in the South, in New York, in the West Coast. It was really consistent and it was also really interesting because it was consistent when we spoke to staff and when we spoke to patients. That was probably one of the unique kind of aspects that NAC brought to this work. And I just want to emphasize that it's really important for us to understand that our health center staff may not all have known how to deal with all of this at the same time when they themselves were grappling with it because of the diversity of where content was available, what public health information was actually reaching them. As you said, that churning of that narrative, the negative kind of quickly outpaced positive. Just wanted to put that in.
Yeah, and it's such an important point. Thanks for picking it up, Wanda, because as I said earlier, we were looking for personas and we were really struggling to try to get stable personas that we thought would be helpful to help you guys in communication. But the narratives, the stories were incredibly stable across all those different contexts. So thank you, Wanda. The formatting hasn't held up here on the slide, but this is just an introduction to one example, which is the narrative number 4, that COVID-19 vaccines are unnecessary. And I just wanted to kind of walk you through the logic of one of these narratives to get a sense about what they look like. So it starts from these histories of discrimination and marginalization and the information mayhem and the suspicion of motives that I've discussed. And these things all seem to leave people skeptical and unconvinced of the need for COVID vaccines. So they kind of predispose people to be skeptical. And then they offer very specific reasons. So they're skeptical because they believe that alternative risk management strategies are adequate. So again, all of these things are things that we heard in the data. That people said that COVID isn't real, or that the seriousness of COVID has been exaggerated, or they perceive the risk of COVID to be very low. They thought natural immunity could manage COVID without vaccines. We heard a lot about divine intervention, and that a lot of people said that natural approaches, different kinds of herbal teas and different kind of natural remedies were sufficient. And then all of these things in their minds then made COVID vaccines unnecessary, which of course justifies the avoidance of vaccines or refusal to be vaccinated. So as we were trying to make sense of this then, it became clear that the narratives themselves and the structure that we were trying to piece together might provide some insights about potential counter narratives, about ways of trying to counter the effects of these narratives that seem to be so prominent, as Wanda said, across all of these different contexts. And so to start this journey off, let's take a second and just orient to what we mean by a counter narrative. So a counter narrative, like the other narratives, they're just stories, they're narratives as well. But in this case, that they're narratives that explicitly aim to displace or undermine the kind of social currency, if you like, of another narrative. In this case, some of the COVID avoidance narratives that I've just shown you. And they do that in two main ways. One, by filling logical gaps in the narratives, by saying, these things have been left out. or by correcting distortions in the framing or the arguments or the evidence or specific inferences that are reflected in the narratives that I just described. And so as we were trying to get sorted out about what counter narratives were about, then it became clear, even before we started to get into developing them, we thought, well, who are these going to be effective for? Wanda showed those slides at the start where there are a lot of people left that still haven't even gotten their second doses. And so who is it that we can move, this idea of the movable middle? And so we started to look at the attitudes that we were seeing in this study. And we heard a lot about suspicion, resentment, grievance, and what we've called antipathy, so a kind of hostility or animosity. And we characterize this as a kind of resistant or a defiant attitude. And then we also heard just a lot of confusion or lack of awareness or lack of understanding about what a virus is, how it works, what a vaccine is, how vaccines work. And a lot of fear and anxiety, I think, that were associated with that kind of confusion or lack of understanding. And so we called this attitude an uncertain attitude. And the question then that we were grappling with was, okay, is there something about these attitudes that can help us figure out who might be movable? And so those were the questions that we started to ask ourselves then. Are these potentially movable attitudes? So then we thought, okay, let's say that could be true. What criteria can we use to kind of figure out how we should develop a counter narrative that might help make some movement in either of those groups? And we found a paper by Tim Caulfield, who's a law professor at the University of Calgary. And it was really about debunking and how debunking works. But it really offered, I think, a set of criteria for effective counter narratives. So according to Caulfield's criteria, an effective counter narrative is one that's amenable to fact-based communications, one that can be delivered in a clear, straightforward, and shareable format, one that can be delivered by trustworthy and independent sources, one where the communication reflects scientific consensus or the best that we have yet about scientific consensus, one where the delivery is, in Caulfield's terms, nice. It can be done respectfully and authentically. And really importantly for us was that it can be delivered in narrative form, and it can emphasize gaps in logic, and that the communication can be led with correct information, and that it can be framed for the general public. So we thought these were all really, really useful ways to think about what we were trying to accomplish with counter narratives. So the first thing we did then was to take the resistant and defiant attitudes and just do a thought experiment to see whether we thought any of those criteria would likely be effective at moving people with those resistant and defiant attitudes. And as you can see here, this is a kind of consensus in the team that we just didn't think any of these things would work on the quite hardened attitudes that we heard in that group. And so that led us to believe then that the resistant defiant attitudes maybe aren't the best targets. Maybe they were not going to be very movable as targets for counter narratives. And then we did the same for the uncertain attitudes. And I mean, this looks gamed, but in fact, if you really think about each of those criteria, we were quite confident that for the right people with the right delivery, that the people with just the uncertain attitudes could be movable. So what this led us to believe was that this uncertain attitude was really the correct focus for counter narratives for their delivery and for looking for people who might be in that movable middle. So a couple of other thoughts about this. The rows in peach color there are really primarily about how information is delivered. So in other words, this is some criteria that's really for communicators. How should you communicate? How should you structure that communication? And of course, communication leads with correct information crosses as well, but let's just leave it here for now. And then the gray ones are really about content. So in other words, they're about which elements of the health narratives could we focus on to try to get the biggest impact with these counter narratives. And so through this process of distillation, then what we ended up with are a scheme of, we've got some targets. We have some sense that people with uncertain attitudes rather than defiant attitudes might be the right focus, might be more potentially movable. We have some ideas about delivery, about how to structure that delivery, how to organize it. And then we have some ideas about content that may help to figure out how to deliver counter narratives or how to structure them, how to develop them. And so with that in the background, then the next question for us was, what parts of these avoidance narratives should we be focusing on, or should you guys be focusing on as you think about the communication with your patients? And there really are, we thought there were two types of narratives and narrative elements that we should be targeting for counter narratives. One is what we called fallacious or just false narratives or narrative elements. So this is primarily focused on instances of, remember a second ago, I talked about narrative fallacy. And it's primarily focused on instances of narrative fallacy, like specific embellishments or simplifications or other kinds of distortions that make the narrative false or invalid or unreliable. And then the second type of narrative is where things are just kind of incomplete or inaccurate or imprecise. They leave out important parts. And so there's just important information missing. And that, again, this is primarily focused on gaps in information or logic, or where people have made kind of unfair inferences or factual errors or important kinds of misrepresentation. So we thought if we could identify some of those areas, those might serve as good targets in the narratives, ways that we can think about intervening. So, another way to think about this is, what's the Achilles heel of the narrative? That element that supports the overall logic of the narrative and may be most vulnerable to intervention or correction. So I mentioned lay epidemiology. We heard a lot about this, about the cousin of the next door neighbor who died immediately after getting COVID vaccine. And this might be an example of where it could be quite straightforward to sort of unpack that a bit for people and let them see that actually it probably doesn't make sense as a broad inference. And it's important to try to figure out, does a clear corrective argument or evidence exist as you're trying to develop a counter narrative? Is there a clear or compelling counter narrative structure or logic, with analogies or case examples or stories or testimonials that you could use as a way to try to counter the effects of the narratives? So if we go back to the scheme that I showed you about the outline of the narrative, what we thought is that in this particular narrative that COVID vaccines are unnecessary, these 6 elements we thought were the best targets. Alternative risk management strategies are adequate, COVID isn't real, seriousness of COVID is exaggerated, perceived risk is low, natural immunity and natural approaches are sufficient. And just to give you a tiny taste of some of the stories that we heard, as an example, under alternative risk management strategies are adequate. Someone said, I used precaution and I did everything that they said to do. And, by the grace of the Most High, I haven't caught it. So it's like, if I continue to do what I'm doing, wearing the mask, making sure employees wear the mask, it's like, why do I have to take the vaccine if I'm safe now? And a couple of comments on the natural immunity. First person here said, I ended up being home in bed, sick with fever, chills, and all of the symptoms. And so, of course, I made that correlation that, yeah, that's probably COVID. And that was even more justification for me that I didn't need the vaccine. And another person said, I got sick already. My body should already have those antibodies, and I should have a stronger immune system because I had it already. Because typically that's how your body works. And of course, that's typically not how your body works and the way your immune system works relative to vaccination. So those are potentially very good ways of thinking about targets. So this is kind of a busy slide, but let me just take a second to walk you through it. For each of the narratives then, and I haven't been able to show you them in detail, but we can share information so that you can see them. We identified analogous elements to the ones that I just showed you, where we think could be good targets for counter narratives. And rather than read them all, I'll just take a second and let you kind of just go through them quickly to see the kinds of things that that were coming out in this work. And we'll work with Wanda to make sure that things can be distributed so you can see this in a little bit more, a little bit easier in your own time. But then, you know, all of this is kind of academic unless we can turn it into some strategies that can be used with patients and with the kind of communications that you all do every day. And so that's kind of the goal. And let me just share some at least of our initial thoughts. The formatting didn't come out on this one either, but this one of the things that we did was we tried to develop what we called a counter narrative template. So the first question is, what are your specific aims for a counter narrative? What effect do you want it to produce? Do you have a specific strategy in mind? How is it expected to work? What's the vehicle for delivering the counter narrative? What are there models that might inspire it? How is it introduced? And you know, what's the reveal or what's the point of the counter narrative that might shift people's mind? And importantly, I think at this stage, we were doing this with the intention of passing this on to people who were going to be developing more full-scale communications, not to develop communication strategies for people like yourselves working at the interface with patients. But I think some of the ideas are still relevant, and I'll just walk through how we were thinking about this. So I'm going to give you a counter example, one that we just worked up. It wasn't our job to develop these counter narratives, but we did a few to try to illustrate how it might work. So this one is an example of a counter narrative that we call the government is your neighbor. And it's particularly relevant, we think, to some elements of the big push, and it's about freedom. And in there, you know, the origins of those narratives really were rooted in suspicion of government and defiance of government and opposition to government mandated vaccination. And so we thought, you know, this is a type 1 narrative. You know, it was kind of a false narrative or narrative elements that we were trying to push against. And the specific aim of the counter narrative is to challenge the idea that government is other and hostile, and to try to humanize government. And the strategy that we used was a kind of visual narrative and to try to incorporate some ideas of paradox. So the vehicle for this, when we were imagining how it would work, would be something like a TV commercial or a YouTube video or some kind of image campaign. The model, I had seen a kind of very interesting Procter & Gamble widen the screen initiative that was about stereotype busting that I thought was very powerful. We set it up in a way of, you know, trying to show iconic American scenes and activities to leverage some of those stereotype images. And then the reveal was to identify individuals within those kind of typical stereotype images as government workers in an effort to kind of stereotype bust, if you like. So this is just the mock-up of what that might look like. So here's a, you know, typical kind of Western American scene. And we say, well, this is a designer with the Montana State Department of Education. Another example, you know, again, a sort of iconic American scene. And our piano player here is an accountant with the IRS, which would actually make him very unpopular probably, but nonetheless, you know, a government worker, and he looks like he's a pretty important guy in this whole scene. And again, a very iconic American image. And here's someone as a translator for the Department of Defense. So, and then end with this, with the kind of overall observation that the government isn't other, it's not hostile, it's your neighbor. The government is made up of people just like you. So that was kind of the idea. So let me finish now with just some final thoughts. First of all, the attitudes and behaviors towards COVID-19 vaccines and vaccinations, we think are shaped by really prominent and powerful avoidance narratives. But the influence of these narratives on patient decision-making, I think, really hasn't been adequately recognized or appreciated in public health communications. The third point is that, effective counter-narratives we think are possible for some target groups and for some avoidance narratives or some specific elements of those narratives. I think really importantly, in terms of handing this over to you guys, developing counter-narratives is very much a creative and collective process. There's no right answer. There's no right counter-narrative that you pull off a shelf. Part of it is about the process of thinking about this and generating ideas. So for NACHC centers, I think discussing and sharing ideas about possible counter-narratives and how they might apply to specific patients or to specific patient groups, like the ones that Wanda laid out so nicely at the start here, they really can provide ideas or concepts or language that you can use in your communications with individual patients. They don't need to be fully realized TV ads. It's part of the process of thinking it through. I think that can be really valuable. So I'm going to end there, but thank you so much for your attention, and I look forward to some questions and discussion. And Wanda, I'm going to move forward to your next slide here.
Thank you. So I'm just going to share some resources and open this up for conversation. But as I stated earlier, NACHC is in partnership with HHS on the We Can Do This campaign. And these are some resources. I think, again, depending upon where you are in the country, resources vary. And so how can we help engage patients and disseminate accurate information? For you at the health center level, and because we work across communities, when you go to the site, there's a lot of resources on that site. And I think about, right up in center and up in front is, navigating misinformation. I think is pretty hard. And now that we have vaccines available for children as well, and so we need readily available content. So when you go to the site, there's shareable resources that you can sort by the type of audience. One of the things I love is that there's multiple languages available. And there's, you could also search by topic as a resource. You can also have boosters and things that you can display in your health center. I will say one of the things that came up over and over and over again was that health center clinicians, nurses are trusted in the community. And if, when you think of the counter narratives and the example that Jim provided on government, depending again where you are, that does impact how people are kind of trying to process information. So what can you help disseminate and get reliable resources out without having to reinvent the wheel, because nobody has time for that, but thinking how you can leverage some of this and thinking through counter narratives. And there's also the NACHC website that has additional content. So with that, I'm going to take off and just put us on like screen. So Bill and I are Jim and I, I'm sorry, are side by side. And I'm not sure if there's any questions in the box from folks, but Jim, as you were talking, one of the things that also stood out for me was that, our health centers were in the midst of this, I think when we were doing the interviews, we were still just kind of coming out from lockdown. And that it was really consistent when we heard where people were. And then 2 weeks later, when we would come back and share some vetted resources, like I remember early on, the emergency use authorization for the vaccine, or we need more information, and you would come back and provide more content. Some people were able to kind of process that, but they still needed the conversation. So being able to have our staff be prepared to have these conversations is like an important strategy. We heard that over and over again so do you have any kind of thoughts about that? You might be on mute. Did he freeze?
I think he froze.
Okay, sorry. Hopefully he'll be back. Maybe some alarms went off in his house. I think the other from, speaking with patients and staff was the health centers had the ability to create a safe space for conversation. We kind of heard that over and over again. When people were provided with the space to reflect and have some of their questions answered, we kept kind of observing that there was a big decision-making burden being placed on people. When you think objectively, none of us, at least even though I'm a PhD prepared nurse, I'm not a virologist or epidemiologist. I'm still struggling with, some of the information, and as well as public health messaging continue to change. So think about that as we think about where people are, and how much work it is to get things out. Can somebody read the questions for me that are in the chat?
Yes.
Sure.
So,
Thanks.
So our first question from Jacqueline asks, and this is a multi-part question, so I might give you part of it and then another. What's the best way to raise the COVID vaccination topic during routine visits? I've come up with leaving COVID vaccination to the end of the visit and saying something like, our clinic offers COVID vaccine to the community.
I think one of the I thought that it was a really brilliant and very easy approach was the Pennsylvania PCA had the staff wear buttons that just said, ask me about the COVID vaccine, or something that says, I'm vaccinated, how about you? So it was a subtle way of introducing or signaling to this conversation about the vaccine. And probably also as part of intake, working with other members of the healthcare team and asking people, their status if you need that. That's one way to do it. But I think, just the visual clues of it were helpful. And also, if you use the data in identifying who still needs to be vaccinated, whether you do text messaging or for upcoming appointments to query who is a potential person that you can have the dialogue with. Next question.
Great. This person says, love the images of government workers. Did the group discern which avoidance problem needed priority attention?
Jim knocked off again.
Yes.
Which avoidance problem? I think from listening to people, the avoidance of more of the distrust was a little harder to move. And then the other was, I think, what was really this conversation of I'm healthy, I don't need the vaccine, or was also kind of another helping people to understand why it was still important to get vaccinated, was another, I think, component of discussion. I will also say that it was really important too to be on the same page with your partner. So when we think about this, I shared earlier that when there was like one negative, conversation or fallacy being shared around COVID, it was really important for the health center and the partner community around them to share the correct information to help disseminate accurate and also dispel some of the things that were kind of catching and a big uptake. We found that, again, depending upon where people were, that they may rely on Facebook groups to get information. So I would encourage health centers to kind of think through. We kind of recommended to host like Facebook town halls or other messaging in the waiting rooms with your own providers that help address some of those issues, and make the recommendation as to why it was a good idea to get vaccinated.
Great. From Carl, he asks, as a CCHW promoting COVID vaccine uptake in the community, vaccine hesitancy is rooted in a lack of understanding of the science of mRNA vaccines. There is little information that presents mRNA vaccine in plain language that is relatable to specific target populations. Can you share your views on developing messaging communication that helps a layperson better understand what the mRNA vaccine is?
So actually on the We Can Do This website, there is a CHW toolkit. And there is some information, I think, that use more lay language to help digest this. I agree. I think that we make it it's too complicated, right? Like I stated before, I'm not a virologist or epidemiologist. You have to break it down in easy steps. And I have come across, well, if you're able to show in a video, I've come across one or two videos that I thought did really good animation to explain it. And I'm pretty sure we have something on, tip sheet that you can use. So we will bookmark this and make sure that we provide content as resources after this webinar.
Another question that came in was that is vaccine hesitancy irrelevant now?
No, it's not irrelevant.
No.
No, it's not irrelevant. If you go to the slide that I started with of where we are, with the geography matters, there's certain parts of the country where, pockets of counties in different states that are less than 15% are vaccinated. I think it remains relevant, and that we need to kind of, take this to heart, especially if there's a health center in this area. It's never irrelevant. It's really about hesitancy, which is my colleague Jenny McLaurin just put in the chat box. I think we need to be mindful and being able to look at the data. I do want to say that I think as health center staff, and I was speaking to someone recently about this, that I think we're fatigued about speaking about it. And so it's important that we ourselves as the front line that are really important to the safety net in our community not get fatigued about speaking about it, because the rates of COVID are going up. Variants continue to, come. And I think that it's important to keep our community safe. And I always kind of remember, again, from the National Academy of Science and Medicine, I was on this, what have been the lessons, what happened to the playbook on COVID. And it's really important for us to remain mindful. We're like maybe one variant away from the vaccine not working. And if we have to, keep the conversation going and make this part of, routine care. But I think it's not just a health center by itself. It requires the partnerships and radio and print and all that to keep the conversation going. I will say that as someone who lives in New York, every hour I get some type of information on COVID and getting vaccinated. And yet I've been in other states where it's almost like it doesn't exist. And so therefore, I think the lift for our health centers is higher. And the burden to kind of talk about it and change the needle on it is higher, because you're not getting this other, the context of the environment around where people live is not getting the same message. Any other questions?
I don't see any other questions. Do you want to plug again how people can find this information after?
Sure. So you could go back to the slide where I have the We Can Do This, where it kind of shows the landing page. And we will be disseminating information after this. The one other resource that I want to share, because I thought they did a really good job, and we'll send this again at the end, was one of the partners in the COVID project was Living Color. And they did incredible messaging and counter narratives and things that were geared towards African-American population. And I love their approach. It was for us, by us. And it was really great content that I think, again, depending upon where you are, My other kind of concern is if you're in communities where there isn't Spanish TV and they're relying on radio, how can you as a health center kind of, get yourself on radio to promote accurate information? We came across certain pockets where people were really just relying on herbs and believing things that were coming in from other places. Again, I think health centers are front and center in helping to change this. If you were to say to me, what keeps me up? I think I'm really fearful of long COVID because we're still learning so much about this disease and what are the implications. And I think health centers are going to be seeing a lot of this in the near future, and we need to be prepared. So the more we can prevent it, the better. Bundling vaccines. I'll have to follow up on the bundling vaccines with someone else and see where that is. Anything else?
Nope, there aren't any other questions.
All right. So I want to thank everyone for participating. You can please email me directly at NAC and happy to continue to have this conversation. If there's resources that you need, please, let us know. I'm also on Twitter a lot. So if you want to follow me on Twitter, I promote a lot. The other resources that I think are really good are Public Health Collaborative does a lot of really good content. For those, I know it's not, the focus is not pediatrics here, but the American Academy of Pediatrics has good content for the stuff coming out. And if you were interested in being a little bit more savvy around navigating mis and disinformation, I would recommend First Draft. That was another one that I thought was really good. And I actually signed up myself to kind of learn a little bit more how to navigate that. So those are just off the top of my head, some of the resources I would recommend. So thank you, everyone. Have a good day and stay safe.